Hi, hello again. Today I'm going to post a bit of a different video. This will be a video of a failed ESD. Now, the reason for posting a failure, I think, is that failed procedures don't really get much airtime in meetings or online. People understandably want to show their successful cases, and that's myself included, of course. But for those of us learning online, I think that can sometimes paint a slightly distorted picture of what ESD practice actually looks like. And honestly, some of the most useful learning I've had has often come from watching cases that hadn't gone as planned. So anyway, I've decided to start uploading some of my failed cases, and hopefully there'll be something to learn from them. So this is the lesion you're seeing on screen. It's a very bulky 10 centimeter mixed nodular LST, which was sitting in the mid and upper anterior rectum, so roughly from 5 to 15 centimeters from the anal verge. So a good portion is above the peritoneal reflection. You have to bear that in mind. And as you can see, it's got a very villous surface which is coated in mucus, and this actually makes optical diagnosis quite difficult sometimes. Now, I have to be honest with you, I haven't done that many very complex lesions. I'm still very much in early stages of a learning curve, but when I do look back at the cases where I've really struggled, it's almost always been this very bulky LSTs. Because as many of you will know, these lesions tend to be fibrotic, they often have muscle retraction, and they're usually quite unstable, which means they keep dangling from one side to the other, and that can make dissection an absolute nightmare. But not just that, they're also very difficult to stage accurately with optical diagnosis and MRI. So distinguishing a low-risk T1 from a T2 or even a T3 is often impossible until you're well into the submucosa. So I think generally most people are quite cautious when approaching this type of lesion. But we do have to bear in mind that this morphology in the rectum has a high risk of occult cancer, which is why we performed full staging here. So we're starting in the retroflected position with some injection. Fluid here I usually use contains gelafusin with a small amount of indigo carmine and a low concentration of epinephrine, which is usually 1 to 100 to 1 to 200,000. Now, as you can see, there's already a lot of oozing, and actually I was surprised to see quite a bit of charring as well of the submucosa just with initial incision. Now, I should mention that we were testing a new knife here, which was the Orice Pro knife, the 2mm. My usual knife is the Flush Knife BTS, which has more of a rounded ball tip. This Pro knife has a flat and disc-shaped cutting edge, which I think translate into higher current density at the same power. So you may notice I'm fiddling around here. I was actually fiddling with the ESU, trying to lower the power setting. You would be forgiven for asking why on earth I decided to try a new knife that I wasn't familiar with such a complex lesion. And the honest answer is that I have no idea, but I suspect I probably underestimated the complexity of the lesion, seeing as that's something I'm still very prone to doing, unfortunately. Okay, so not the cleanest of incisions, but we finally managed to reach the muscle layer. You can clearly see the circular muscle fibers now. So we're just extending a little bit, and this will just provide the exit to the pocket. Once the oral side incision is complete, we then move to forward vision, and a neat little trick during injection is to use RDI or NBI to avoid puncturing large submucosal vessels during injection. I have to thank my colleague Renzo for reminding me to switch it on, because honestly I forget about it most of the time. And I haven't really used RDI much during dissection, but the deeper submucosal vessels really show up very clearly, as you can see. And this way we can avoid puncturing them, which can be a bit of a pain at the beginning, as it creates a submucosal hematoma which obscures the field. And we can also see them during incision, so we can employ the coagulation current appropriately to reduce bleeding. So it's not strictly necessary, of course, but these small things I think do add up in the end. Okay, so that looks much better actually. We've got a nice blue submucosa, which is what we're looking for, with no hematoma, no active oozing, and no charring. So I've now fast forwarded to inside the pocket, and we've switched to saline immersion or sight. Now, if you've watched any of my other videos, you'll probably know that this is my go-to technique. And as I've explained before, the main advantages are the optical magnification, the absence of fogging, which means you don't have to keep bringing the scope out and cleaning the lens. And then there's also the stability and the natural traction provided by the buoyancy of the lesion. But as you see, I mean, it's mainly the views, isn't it? Because if you look at the submucosa, it's just nice and expanded, almost transparent, and you can clearly see the vessels. So for me, these advantages are really unparalleled, and it actually couples quite well with pocket creation method, because the pocket helps keep the fluid contained. So all in all, when I can use this technique, I usually will. Some experts complain a bit about the bubbles, the creation of bubbles during sight technique. I've not really found this to be much of a problem. I mean, I keep actively flushing all the time with my free foot. But generally, as you can see, it's not much of a problem, and when it is, I'll just either flush them or suction them. We can already see the first penetrating arteries here, which are pulsating. So I'm working my way around them slowly, trying to isolate them and trying to get a sense of how many of these vessels I see, so as to decide whether or not I'll need the coag grasper. So there's another visible big vessel trunk or group there. So that's 3 in a small confined space. So I'm already telling the nurse to open the coag grasper, because I usually try not to use it unless it's strictly necessary. But I mean, in a lesion this size with this many vessels, and in particular with a new knife that I'm not familiar with and I'm not sure how well it's going to perform pre-coagulating vessels, I think it's pointless waiting. You might as well, if you're going to open it at the very beginning and start sealing the high-risk vessels. Okay, so for coagulation, I usually bring the power up a little bit when under immersion. I get a sense that some of the heat or the energy is dissipated with the immersion, so it's usually 100 watts minimum I'm using here, and you have to be a little more patient as well. Because a lot of the time, or it's happened before, the vessel looks completely sealed, then you cut through and it starts bleeding. So it's best to take your time, I think. So a lot of coagulation going on. Another tip I think is to isolate several vessels in one go. So have many of the larger ones isolated. So once you bring out the coag grasper, you can do them sequentially rather than having to isolate one, switch to the coag grasper, then back to the knife, then back to a coag grasper. I think it just speeds things up a little bit. We're now ready to cut through the vessels, through all the vessel groups, and I think it's generally a good idea, as I've done here, is to suction some of the fluid and go back to the CO2 medium, because if you're cutting through a high-risk vessel or vessel group and it starts bleeding and you're under immersion, you're almost certainly going to get an immediate red out. That can complicate things quite a bit. So generally, unless it's a very small vessel, which I'm confident won't bleed, I'll generally try and remove the fluid so that if it does bleed, if it's in a non-dependent position. Okay, so I've fast forwarded and we're now roughly 8 centimeters into the pocket, but we've now reached an area of clear loss of plane, so there's visible muscle retraction here. The strategy is usually to try and open up the sides a little bit and then draw an imaginary line that between both sides of open submucosa, and sometimes you can see the contour of the muscle, as is the case here, so I try and follow that ever so slowly. Okay, so I'm playing this in slow motion just so you can see that sometimes the blunt dissection of the cap is sufficient to rupture a vessel. So fortunately this wasn't too large, but you know, it's just something to bear in mind as well. If you're exerting too much pressure into the submucosa, a lot of times you will tear these vessels or the cap. Okay, we're back at the target area with the muscle retraction. So bottom right, you can still see more or less the contour of the muscle, and you can also see a tiny bit of open submucosa right by the knife. So I'm trying to imagine a straight line from one side to the other, and slowly and steadily just cutting across. But at this point I'm quite concerned by the view of all these neovascular changes which I'm seeing here, with a great number of distorted and abnormal vessels. To me that suggests probably deep infiltration more than pure muscle retraction. But again, I can still somewhat see the contour of the muscle. You can see it here. So I'm trying to stay just a couple of millimeters above it and cutting across. It's not always easy, but there's the submucosa at the bottom. Got the muscle on the right, so I'm just following that fiber. But again, quite concerned by the view of these vessels. So I'm looking at this now and kind of hoping that a few more passes with the knife and it'll open up, as is sometimes the case when it's a true muscle retraction. But unfortunately, as you will see in a minute, this happens. Now, when I first saw this, I really wasn't sure what was going on. The tissue there doesn't look clean. It certainly didn't feel as if this was the exit to the pocket. But I'm very, very close to the muscle, because you can see the contour of the muscle just there. Yeah, so at this point I'm concerned I've probably perforated through the specimen. I'm not entirely sure what's going on. I'm seeing some blood coming through there, as you can see, so I'm trying to coagulate it. But then I realized that's probably just the fluid that's coming in from the other side. So here's where things start going downhill. I decide to continue on the side, but I hit a vessel and start to bleed. Now I'm trying to tamponade with the cap, but that tears an even bigger hole into the specimen here, and you can see the vessel up top there. And now I'm under immersion, so I'm having to exert a lot of pressure with the cap because this is actually an artery and I don't want to get a complete red out here. So I'm now switching to the coag grasper while maintaining very firm pressure with the cap on the vessel. So fortunately I managed to control the bleed relatively quickly and decide to keep opening the side here a little bit while I can to get a better assessment of the situation. Unfortunately, the submucosa was becoming increasingly vascular and deformed. I was really struggling here to understand what the direction of the plane was. And predictably I hit yet another vessel, because this turns out to be a complete minefield. Okay, so I'm now having second thoughts. I'm moving in and out to see the distance to the exit, which is actually surprisingly small, probably about 1.5 centimeters, and I think that's what kept me going. But again, as you will probably see here, I've clearly, with all this pressure and maneuvering, I've ruptured through the specimen, so this is not an R0. which is relevant if it is an invasive cancer, but of course I don't know for certain yet, though it certainly looks like it retrospectively. But it's been almost 3 hours now, and given the situation, I'm starting to seriously consider aborting the procedure. I finally decide to give it one last go by lowering the dissection plane in case it's fibrosis, but unfortunately, as you can see, I'm going to freeze the image here, try and spot the vessel, and 3, 2, 1, boom, we've got another arterial bleed. Now again, I'm putting a lot of pressure with the cap while I reach for the kayak grasper in order to avoid the formation of a huge clot while under immersion. But unfortunately, this is a much more serious bleed. It's obviously a thicker vessel, so I decided to try and suction the fluid and shift the patient around, see if I can get the bleed into a non-dependent position. So I need to take the chance to suction some of the blood that's pooling, and we're quickly moving the patient onto his back. So we've managed to position the patient so that the bleed is in a non-dependent position. As you can see, it's a very brisk bleed, but this way I'm reaching for the kayak grasper again, and hopefully we'll be able to control it like this. So after a very stressful couple of minutes, we finally managed to control the bleed. So we're going to check the situation, and again, having exerted a lot of pressure, I've just torn right through the lesion here. It's now very obvious what's going on, and I'm now pretty certain that this is no longer a T1. So despite having completed almost 90% of the resection, I decide the safest and most reasonable option is to abort.